Today, I'd like to welcome Dr. Goldstein, who is a board-certified adult, adolescent, and child psychiatrist and the director of psychiatric telehealth services in the Division of Child Psychiatry and Psychology with the Bingham Clinic, U of L Department of Pediatrics, and Norton Healthcare Division of Child and Behavioral Healthcare. She did her psychiatric residency and child and adolescent psychiatry fellowship at the University of Kentucky. Dr. Goldstein then practiced about 10 years in Atlanta before returning or coming to Louisville. She worked initially at the Lee Specialty Clinic before joining the Department of Pediatrics, and her clinical interests include patients with developmental disabilities, telepsychiatry, integrative medicine, and patients with complex medical and psychiatric issues. So I'd like to welcome Dr. Goldstein, who is going to talk to us about management of antipsychotic medications. And Dr. Goldstein, you can share your screen now.
Okay, thank you. First off, just to let everybody know, I have two disclosures. One is I'm a consultant for Alliant, and also that my husband actually works for a pharmaceutical/insurance company. He works for Anthem Insurance and Genio RX. Next slide, please. So also during this talk, I will primarily talk about on-label usage of antipsychotics in children and adolescents, but there will be some mention of off-label usage, so I wanted to disclose that as well. Next slide. Our objectives are to talk about the different types of antipsychotics, delineate the side effects of the antipsychotics, and discuss the monitoring requirements for patients on antipsychotics. So my goal today is when your patient comes into your office and they're on an antipsychotic, that you know what to look for and what to watch for. Not necessarily how to prescribe them. From what I know from most pediatricians, they really prefer for the psychiatrist to prescribe them. So when would be a situation that a doctor might actually use an antipsychotic in a child or an adolescent? Typically, it's when the patient is a danger to themselves or others, mood cycling or manic episodes, if they're showing a significant deterioration in emotional, behavioral, and their level of normal day-to-day functioning, if they have psychosis, meaning hallucinations, audio, visual, they're very paranoid, if the doctor has tried the patient on medicines with fewer side effects that are not effective. In patients with severe trauma, they sometimes benefit from the usage of antipsychotics, and agitation and irritability in autism spectrum disorder and Tourette's disorder. Next slide, please. Just as a reminder, we probably all are aware of this, but the medications will not resolve family stress or family stress or conflict, abuse or neglect, poor parenting strategies, school stress or conflict, a strong-willed child, intellectual deficits, or developmental impairments. Next slide, please. So how do you know when a patient's medicine is actually working for them? So you don't want to see that the child is sedated all the time. You want them to have a lower, more manageable energy level. You want them to be calmer, coherent, in many cases more interactive, more engaging, more focused and attentive, and hopefully less irritable as well. Next slide, please. So I'm going to introduce a concept that is going to come back again presented by Dr. David Lohr in the future, and it's a concept called deprescribing. And I think it's important when you're thinking about the usage of medicines to think about also what's our exit strategy? How can we get the patient off the medicine? Or are we making sure that the medicines that the patient is on are all needed and are at the appropriate dosages? Deprescribing is a systematic approach to evaluating each medicine to a child for each of them to have a rational use. You want to understand what the patient's diagnosis is and what the indications are. You want to look at or make sure, in the case of a pediatrician, you want to make sure that the family understands what are the risks versus the benefits. You want to make sure that the family understands what the side effects are of the medications. You want to look at the medication and the overall treatment of the child to make sure that these are the right medicines for the patient to be on. What are their ultimate long-term goals? And are they things that medicine would help or medicine is hindering? Next slide, please. So many antipsychotics are prescribed off-label for disruptive behavior and aggression. In our quick fix world, medicines are often the answer, even though in many cases, patients may respond very well to psychosocial therapies or medications that maybe address ADHD symptoms. Also, children who have a significant trauma history may actually respond better to therapy, and the presence of being placed in a safe, nurturing environment. It's amazing the difference it makes when a patient moves from being in 6 different foster homes in 6 months to being a whole year in the same place. Also, we want to take patients off the antipsychotics because there are significant short and long-term side effects that often require ongoing monitoring. Next slide, please. So what are the different types of antipsychotics? So there's 2 big groups. There's the first generation, next slide, please. There's the first generation and the second generation. The information that goes to both slides are where they have things in similar, and then the ones where there's differences, you'll see it's explained. So first generation antipsychotics are the older antipsychotics, Haldol, Stelazine, Thorazine. They block most of the dopamine receptors, actually all of the dopamine receptors. Amongst the class of first generation, they are all equally effective. The difference often is how they impact a patient and their side effects. The first generation antipsychotics have no effect on serotonin receptors. As in contrast, so the second generation antipsychotics are also equally effective, and again, it's the side effect profile that influences which antipsychotic a psychiatrist may choose. The second generation antipsychotics, unlike the first generation, don't have equivalent dopamine receptor affinity. They are much more variable in their affinity for the dopamine receptor. They are also, and this is one of the big differences between first generation and second generation, is that they are strong serotonin 2A receptor antagonists. All the antipsychotics work on the mesocortical and mesolimbic dopaminergic pathways. So first generation antipsychotics are more well known for reducing the side effects of aggression, agitation, and positive symptoms of psychosis. In just a second, we'll talk about what positive symptoms are. Second generation antipsychotics, when they first came out, the belief was that they did a great job of reducing negative symptoms of psychosis. And the research I was doing more recently says that that actually is no longer the blanket statement that it used to be, and they're very variable. First generation antipsychotics, all of them can cause an increase in prolactin, which we'll talk about the effects of that in just a minute. And then also, for the second generation, the only 2 drugs that do this on a large scale are risperidone and Invega. Both medicines can cause extrapyramidal side effects, and but the second generation is typically shorter. And first generation is known for causing neuroleptic malignant syndrome, but second generation is known for causing weight gain and metabolic syndrome. Next slide, please. So the types, as I mentioned, the types of psychotic symptoms. There's positive symptoms, and think of these as being more active side effects. So these are things like when the patient has delusions or is responding to internal stimuli and experiencing hallucinations. They have repetitive movements or confused thoughts. They may have very disorganized speech. Negative symptoms are things when the patient has a blank look, they're not engaged, they have an inexpressive face, they don't have any gestures or movements, they're off in their own world and not really interacting with other people, their speech is monotone, they may be unable to feel pleasure or act spontaneously. Next slide, please. So just to give you some ideas of the first generation antipsychotics, these are such medicines like chlorpromazine, prolixin, haldol or haloperidol, perfenazine. Next slide, please. So which ones are the second generation atypical antipsychotics? And these in general are going to be the ones that you're going to see more commonly than the first generation. I would say, especially in children and adolescents, we are more likely to go to a second generation than we are to use a first generation. Although for patients who've been tried on many medicines, oftentimes going back to a first generation medicine is more effective. So these include aripiprazole, acenapine, brexpiprazole, cariprazine, clozapine, iloperidone, lumateperone, lurazidone, olanzapine, paliperidone, quetiapine, risperidone, and ziprasidone. And as a handout associated with this, there is a full chart with dosing and side effect information of all of the, I think it has both the typicals and the atypical antipsychotics, but it for sure has the atypical antipsychotics. Next slide, please. So we were talking about dopamine receptor occupancy. So when the antipsychotics occupy no dopamine, there's no effect on the patient. When 60 to 75% of the dopamine receptors are occupied by the medication, you see the impact and the effect of the antipsychotics. But once you go over 75%, and the closer you go to 100, the more extrapyramidal side effects that you'll see, and the more negative impact you'll see of the medication. Next slide, please. So what is the time frame that antipsychotics begin working? So all the antipsychotics begin to block receptors almost immediately. Peak plasma levels are obtained within 1 to 4 hours, especially when doses are given orally. IM formulation, which is typically done in the emergency room or inpatient units, typically takes effect in about 15 minutes. We have multiple long-acting depot formulations, which are beyond the scope of this talk, but those are typically lasting about 6 months, or take about 6 months to reach steady state, and then have a variable amount of time that they last in the patient's system. As with anything, patients' responses to the medicines vary. I wish there was some magic that we could say, oh, you're this type, you will respond better to this medication, but unfortunately we don't have that. The medicines all have variable half-lives. Next slide, please. So what's the timeline for antipsychotics? So your patient was sent to a child psychiatrist and started on Risperdal. How long would you or they expect it to take until they see a response? What I typically tell families is that it's about 4 to 6 weeks before I see a true response from an antipsychotic. Sometimes it's very quick. Sometimes even just the sedating aspect of some of the medicines is helpful because then the patient gets better sleep, and so that helps things too. If the patient has a partial response at 4 to 6 weeks, then very often increasing the dosage for another 4 to 6 weeks is beneficial before switching to something different. Now, if there's no effect or if there's negative effects, then you'd want to consider a different medication. It's very important when you have patients with true psychotic symptoms to ensure that they don't relapse, to help emphasize the importance of continuing the antipsychotics, as there are multiple negative effects on the brain with multiple episodes of untreated psychosis. Generally, the literature recommends that for a patient that has had their first psychotic episode, that they remain on the antipsychotics for at least 1 to 2 years. For a patient that has had multiple psychotic episodes, they require at least 5 years of treatment. Next slide, please. So now we're going to talk about what are some of the side effects, because this is what the pediatrician is going to see. Next slide, please. So first, we're going to talk about some general side effects that really impact both the first and second generation of antipsychotics. The first group of side effects that I'm going to talk about are the cholinergic effects. And I go back to my mnemonic that I learned as a med student: red as a beet or skin flushing, dry as a bone, dry skin and mucous membranes, hot as a hair or running a fever, full as a flask, or urinary retention. Most likely, I would imagine that urinary retention wouldn't necessarily show up in a pediatrician's office, but if it does, it can typically be treated with bethanechol 15 milligrams 3 times a day. Mad as a hatter, or altered mental status, and blind as a bat, which is mydriasis or pupil dilation with no accommodation. Next slide, please. So the next group of symptoms that we're going to talk about is the extrapyramidal symptoms. This is a large group of different kinds of symptoms that you can see, and over the next few slides, we'll describe exactly what some of they are. So some examples are dystonia, rigidity, tremor, akathisia, and pseudoparkinsonism. These are often seen in young patients. Also, they can be seen in patients not just on the antipsychotics, but also on metoclopramide, otherwise known as Reglan, or prochlorperazine. So an acute dystonic reaction would typically occur shortly after starting the patient's medication. Often it is shown or seen as a sustained contraction of muscles, usually the neck, mouth, or tongue. And it's often treated with benztropine 1 to 2 milligrams or Benadryl 25 to 50 milligrams. Next slide, please. These are just some quick examples of different types of dystonic reactions that you can see. So for example, torticollis is where the head becomes persistently turned to one side with painful muscle spasms. Macroglossia, where the tongue protrudes and feels swollen, even though it's technically not swollen. They can have a buccolingual crisis where they have trismus, where they have this grinning expression that's produced by a spasm of the facial muscles, and also spasms of the vocal cords. Next slide, please. So there's 4 different kinds of dystonic reactions that are shown on this slide. One is dystonia, which we've talked about. That's where the neck protrudes in a single direction and doesn't move and can be very uncomfortable. The next one that I mentioned is akathisia, and that's an internal sense of restlessness, and it's an inability to sit still. So the picture sort of describes it in picture B. And then in picture C, it has pseudoparkinsonism. That's where a person has muscle tremors, cogwheel rigidity, drooling. They may be very slow in their movements, and they have a shuffling gait. The similar symptoms that you would see in a patient with actual Parkinson's disease, but not Parkinson's disease caused by brain, but caused by the medications. And then tardive dyskinesia is abnormal muscle movements, often found in the tongue, and I'll show you an example of those. So this first one is an example of a dystonic reaction in a patient in the ER, and I'll show you, this is what happens sometimes when patients get antipsychotics. Can you play that video?
So, when did you start having trouble talking? Early this morning? And did you take any drugs? Other than your prescribed drugs? No? You don't do cocaine or anything like that? No? Okay. Count to 10 for me.
1, 2, 4, 5.
Okay, that's good.
Yeah. Wait.
I do. I feel better. I feel like I can talk.
We'll get that level on as well.
I said what I want to say now.
All right. Cool.
I feel better. I am glad I came to see you all. Hey, glad to see you all here at MCG.
Quick question. Has the pupil on this eye, has it been bigger than the pupil on your other eye for a while?
Yeah. Yes, it has.
It has. Okay.
It has.
Okay. But has that ever been ever since you had your head injury?
Yeah.
Okay. You still want to spin the head?
Let's talk about it. Count to 10 for me now.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
All right.
1, 2, 3, 4, 5.
Now he's hamming it up. Okay.
Yeah. I feel better. I feel better.
Now your voice isn't perfect, but is this how you normally talk?
No.
Not yet. Not yet.
I had to take it.
Yeah, but your speech is still a little slurred.
Yeah, because I had to take it out of myself.
Okay.
I don't feel better right now. But the doctor said, give me some Benadryl, and the doctor knew exactly what the purpose was. The purpose was to give me some Benadryl, and that's what they did for me. Give me some Benadryl.
Now, are you talking back to normal for you? Is this how you talk?
Yeah.
Okay, all right. So you had some traumatic brain injury sometime in the past, is that right?
They cut my brain.
Okay, and so, but you have some psychiatric issues too that you're being treated for.
I be having flashbacks.
Flashbacks. Hey, so you have your right guard over there, and sometimes people actually huff that to get a high on it.
What?
Yeah, but were you using the right guard at all?
No.
No, you weren't.
I just use it for deodorant.
For deodorant, that's using it like it's supposed to be good. Okay,
Yeah.
well you're very kind to the rest of us, you know.
You're
That's thoughtful.
very kind too.
Okay, we can stop the video.
For
Thank you. That shows you an example of a patient who comes in with a dystonic reaction, and then they get the Benadryl, and then how their symptoms improve once they've been given the Benadryl. Next slide, please. So as I mentioned before, akathisia is a feeling of restlessness, anxiety or tension or fidgetiness. It often will come across when patients tell me that they want to keep moving, or a patient maybe who's normally very sedentary is constantly pacing or walking. They often, like I've described it to patients as feeling like you have ants in your pants and you can't sit still. It's relieved typically by lowering the dose of the antipsychotic or using beta blockers, amantadine, clonidine, or benzodiazepines to help relax the side effects from that medication. Next slide, please. So also tardive dyskinesia, which is an abnormal involuntary movement, like we talked about, typically involving the mouth or the tongue. It's caused when there's a supersensitivity to dopamine following prolonged receptor blockade of the dopamine receptors. So often tardive dyskinesia used to be seen in patients who had been on antipsychotics for 30, 40 years. And it was the side effects of them being on it. Nowadays, I feel like we are more careful to intervene, and also now there's some treatment. So one of the things that is sometimes helpful is just starting vitamin E, 1,600 units daily. Also, there's 2 new medicines out there. One is called valbenzine, and one is called deutetrabenazine, Ingreza, and Austedo. And I haven't put many patients on them because I don't see many patients with tardive dyskinesia, But the couple of patients that I've put on them, the impact was pretty phenomenal. That one patient in particular, his tardive dyskinesia went completely away. And it was life-changing because this was a man who had trouble talking and had trouble eating and couldn't be understood by people, all because of his tardive dyskinesia movements. Next slide, please. So the first video is an example of a little girl with tardive dyskinesia. Can you show that video clip? And she actually has movements throughout her body from the antipsychotic. Sometimes it's a little tough to tell what's her chewing versus what's the abnormal movements from the medication. But she is quite a long period of time without seemingly chewing that it looks like she has all these abnormal movements.
He said he gave you the topic to your final essay.
See how she can't sit still? She's constantly fidgeting.
Word in 2 hours for the exam.
I wrote it in my head. Put it down.
In your head.
Wouldn't it make a difference anyway? They just want us to spit back exactly what they want to hear. I have an opinion, it's just not their opinion.
Well, their opinion is that you should repeat the year. Just throw it away.
Okay, you can stop that clip, please.
You can go to a private.
And then the next clip, these show two people with more typical older tardive dyskinesia that I've seen in older patients. Can you play that clip, please? It's subtle, but you see their mouth movements. Next slide, please. So as I mentioned earlier, another side effect of the typical antipsychotics and some of the atypical antipsychotics is hyperprolactinemia, which is an increased production of prolactin, which can lead to milk production from breasts, even in males. And in males with an elevated prolactin level, they also will have increased breast development and not just a fat pad. They may have the leakage from their breasts as well. For women, they may have irregular periods or no periods. They may have acne or excessive hair, vaginal dryness. Oftentimes with when there's hyperprolactinemia from the antipsychotics, we'll treat with bromocriptine, or more often, at least in my experience, I've taken the patient off the offending medication. This is much more likely in the first generation, like I mentioned, than the second generation. And as an FYI, it's in patients where they have to be on a medicine that helps their psychotic symptoms or mood symptoms, but causes the elevated prolactin. In some cases, when those medicines are therapeutically necessary, you can add about 2.5 milligrams of Abilify, or like a small dose of Abilify, and that will actually help decrease the prolactin. Of course, then you have a patient on 2 antipsychotics, which sometimes is problematic in and of itself. But when you have a patient who is only responding to a certain medication, sometimes you have to resort to that. Next slide, please. So 2 disorders that I thought it was important to talk about that can be side effects of the antipsychotics is neuroleptic malignant syndrome and also serotonin syndrome. Now, serotonin syndrome is not typically caused by the antipsychotics, but the two can be easily confused. As you can see, it's helpful to look side by side at the different side effects. Both can cause confusion and delirium, elevated temperatures, sweating, heart rate. Typically, NMS has more of an unstable blood pressure, whereas serotonin syndrome has just elevated blood pressure. So one big difference between the two is that NMS has generalized muscle rigidity, whereas serotonin syndrome has more clonus and hypotonia, or low muscle tone. Also, lab findings in NMS are an elevated CPK and also a leukocytosis, which would not be found in serotonin syndrome. Next slide, please. Also, some of the antipsychotics can prolong the QTC interval. There was a controversy when ziprasidone, which is one of the atypical antipsychotics, came out with it causing prolongation of the QTC interval. I think subsequent research has really shown that it hasn't, but I think it still has sort of put fear in a lot of people anyway. So it's often helpful, especially in a patient on Geodon, to do a EKG at initiation of treatment, although I don't believe that that's recommended in like the ACAP practice parameters. But other medications, especially for a patient that's on a lot of different medicines, can prolong the QTC interval. For example, risperidone, flufenazine, risperidone, ziprasidone, and quetiapine are probably the ones that you would see the most. And where I get concerned as a psychiatrist is typically a child with a 440 millisecond QTC interval. It's kind of borderline, and anything greater than 460, I start to become concerned and monitor what medications we're starting and doing EKGs anytime there's new medicines or new dosing added. So here is a list and a chart of the different side effects of the atypical antipsychotics. They're listed by how common they are, and a lot of these we've talked about already. Weight gain is a big side effect for the atypical antipsychotics. Typically, it's olanzapine, risperidone, Seroquel are the highest that cause weight gain. Actually, I think clozapine and olanzapine are pretty close to as far as weight gain goes. Abilify was believed to be low in the weight gain department, but I'll tell you, with some pediatric patients especially, they've still had some significant weight gain. And we're talking patients gaining 10 pounds in a month or gaining 10 pounds in a couple of weeks. And then Geodon and some of the newer antipsychotics like Rexulti and Latuda seem to hopefully have less of an effect on weight, but it's hard to know because at this point, a lot of them haven't been used much in kids. The muscle rigidity that we talked about, that's the dystonia, the Parkinsonism. Constipation is a huge issue in many of the pediatric patients. And it's difficult because I find myself, even as a psychiatrist, prescribing families to use continuous bowel regimens or to go see their primary care doctor to maintain a stable bowel regimen because they end up just trying to be reactive instead of being proactive when the patient has constipation. Dry mouth, dizziness, also sometimes orthostatic hypotension. Actually, it's listed in the second one, but a couple of the medicines have bigger issues with that, like Zyprexa has orthostasis and Seroquel has orthostasis. Also, sleepiness and fatigue. Zyprexa can be very sedating. Seroquel can be very sedating. I'm trying to think of risperidone. Sometimes it changes more the sleep architecture. So in some patients, it makes them sleepy. One of the things, I don't think I put a caution in here before, but it's common, or it was common, to see people prescribing antipsychotics as a sleep aid, particularly quetiapine or Seroquel. And just as a don't do it, it's giving a person a medicine with a lot of side effects for a reason for which we have a lot of other medicines and interventions that we can try with much fewer side effects. Some of the less common side effects, headaches, the elevated blood glucose, elevated cholesterol and triglycerides, this seems to be more specific to the atypicals, and it causes a metabolic syndrome. And we don't quite know the mechanism of action. It doesn't seem to be quite just the developing an insulin resistance. And also many times the patient's appetites will increase exponentially. So we have to counsel families on locking up sweets, working on eating healthy. And then the rare reactions, but rare but significant, like the TARDIVE dyskinesia, neuroleptic malignant syndrome, clozapine or clozaril will knock out your white blood cells, and actually that requires weekly blood draws, and so that's a big one for the lowering of blood cell counts. And elevated liver enzymes in the prolonged QT interval, and elevated heart rate or tachycardia. Next slide. So what is some of the monitoring for people taking antipsychotics? I feel like this is probably one of the most important things for pediatricians to know. I've been surprised sometimes when patients will tell me that they've been on antipsychotics for 3 or 4 years and nobody's drawn blood or nobody's taken their blood pressure. And sometimes it's because the family hasn't gone to the patient hasn't gone to their primary care doctor in a while, and other times I'm not sure exactly why. But anyway, so typically before treatment, you want to get a baseline weight and a waist circumference, and then repeat it again every 6 months for the first year, and then every 12 months after that. I typically try to get weighted every visit, although I have to say that's been one of the disadvantages of telehealth, is that I have a lot of patients right now that I don't have weights or blood pressures because they don't have any of that equipment at home. It's been a little surprising how few people actually have scales at their houses. So blood pressure is another vital sign that we want to take at least before starting treatment, and then at 6 months and at 12 months, and then every 12 months after. Especially if they begin to gain weight, you want to monitor the blood pressure. Also monitoring their serum lipids, their fasting blood glucose. I also add hemoglobin A1C typically just to help me monitor their blood sugar as we're continuing along in treatment. Also, you want to monitor them for any abnormal movements. Does mom or dad see something different that they didn't used to see? Or do you see something different in the patient? Are they moving their arms or shrugging their shoulders, or their tongue is moving around a lot? Those are all things to note as the pediatrician, and to either mention it to the family or to coordinate care with the psychiatrist. Also, are there menstrual problems? Are they all of a sudden not having a period and they're not pregnant? And then also, are they having, even in males, asking if they've developed breasts, or are they having any milk leakage? Because that could be from an elevated prolactin level. Next slide, please. So some of the things we talk about with families, I as a psychiatrist, and hopefully the pediatrician does too, or I know most of the pediatricians I know do. You want to talk about healthy eating. You want to try and keep their BMI at less than 25. You want to encourage exercise. It's a hard population sometimes to do all those things, but just keep encouraging. You want to monitor the weight, the waist circumference, the fasting glucose and lipids. I also will sometimes give some dietary advice, including things like small, frequent, slow meals with water, reducing sugar, saturated fat, and processed white flour, increasing fruit, vegetables, and fiber, and encouraging the exercise 30 to 60 minutes a day. Next slide, please. So this is a list of the antipsychotics that have pediatric indications by the FDA. And so you'll see, so aripiprazole or Abilify has indications for schizophrenia, bipolar disorder, irritability associated with autism. It's typically dosed starting at about 2 milligrams, but can be increased as needed. And it's generally indicated for autism, it starts at age 6. For bipolar, it's age 10, and schizophrenia, it's age 13. You'll find that except for autism, almost everything is 10 and above. Next slide, please. Aripiprazole also has an indication for Tourette's disorder, and these two different options, one is when the child weighs less than 50 kilograms, and one is when they weigh more than 50 kilograms, and just changes a little bit of what the dosing is like. And then asenapine or Saffris is another one that has an indication for bipolar mania in children 10 to 17 years of age. And the next one is olanzapine, which has an indication for schizophrenia or manic episodes or mixed episodes in bipolar disorder, also for 13 to 17. Next slide. And then olanzapine also has an indication for adjunct therapy for bipolar disorder. Starting dose is typically 2.5 milligrams at bedtime because of the fact that it makes the child sleepy, and can be started at age 10. And sometimes what you'll find is that even if you have a patient that's younger than these indicated ages, it can be challenging to get the insurance companies to pay for some of these medications unless you have really convincing reasons or they've failed multiple other medications. Paliperidone, 12 to 17, also for schizophrenia. Quetiapine, also for schizophrenia. Next slide, please. And bipolar mania, quetiapine, long-acting quetiapine is also for bipolar mania and schizophrenia. Then risperidone is for schizophrenia. Next slide. And bipolar mania, and then also the irritability associated with autistic disorder. And then risperidone typically starts at 0.25 once a day, maybe twice a day, depending on what's going on with the patient. And then, like it says here, there's a information about lorazepam also has a pediatric indication. There's a full chart in that handout that I provided. Next slide, please. So just to summarize these indications, for schizophrenia, it's risperidone, aripiprazole, quetiapine, olanzapine, paliperidone, molindone, and haloperidol. For bipolar mania or mixed, risperidone, aripiprazole, quetiapine, olanzapine, ziprasidone, asenapine. For bipolar disorder, it's bipolar depressed as an adjunct, and that's for olanzapine and lorazepam. Next slide, please. Irritability associated with autism is risperidone and aripiprazole. And then Tourette's disorder is aripiprazole. And then, as I mentioned, there's additional information about all the atypical antipsychotics is in the handout. Next slide. Any questions?
A couple questions, Dr. Goldstein. With the prolonged QTC or QT interval, what level do you consider stopping the drug?
450, 440 for 450.
And then a question about the type 2 antipsychotics. They also can cause serotonin syndrome?
They could, especially if they were used with a patient who's on a lot of other serotonin medications like the SSRIs, although it's pretty unlikely. I can't say that I've seen it.
Okay. And then if patients are coming to the pediatric office and they're on these medications, what do you suggest the pediatricians do about the dosing? Do they need to call you all or have the parents call you all, or would you feel comfortable with pediatricians altering the dose?
If the person is actively involved with a psychiatrist and there's an issue with the dosing, I would generally suggest talking to the psychiatrist rather than adjusting the dose yourself if you're seeing side effects. I think otherwise what happens is the pediatrician changes it, the family comes to the psychiatrist, and the psychiatrist has absolutely no idea why, and the family can't tell them why it was changed. So I think it's better to start the communication with the psychiatrist instead of the pediatrician trying to change it themselves, assuming that is that somebody is actually involved with an outpatient psychiatrist.
Okay. All right, Dr. Goldstein, thank you. That's all the questions.
Okay.